Good morning, a warm welcome from London. My name is Malte Gerhold, and I'm the Director of Innovation and Improvement at the Health Foundation and a Q member. It is a pleasure to host you for this session on bringing together digital and improvement to transform our work. How do we navigate the tensions between new technologies and improvement work? I'm looking forward to this session and some exciting guests, but before I introduce them, a few technical points for you for the session. Live captions are available for the sessions if you would like to use them. You can click on the button to enable those. The session is also being recorded, so it can be viewed afterwards. The conversations that we're having later in breakout rooms will not be recorded, so you can speak privately in those. And finally, if you want to tweet about the session, you can see there on the screen our tag for the Q community and the hashtag for the event today. Right, so an overview of the session today. What have we planned? Now, we know that over the last few years, the new technologies and new availabilities and opportunities of data have made a big difference to the context in which we work in health and care. But it's also raised a lot of questions about how technology and data can be used in the best possible way as part of our improvement work and innovation work. So in this session, we want to explore this particular topic, but also celebrate some of the work that has been done by Q members through our Q Lab work and Q Exchange work in this space. It's also a session that's very relevant to us here at the Health Foundation because we're increasingly focusing on the use of new technologies and data in making change happen. And so it's a debate that's really interesting for me personally as well. We also want to encourage this to be a different type of conversation, to be very open and honest about some of the challenges and problems and tensions we face when new technologies and improvement work come together. We're going to have the conversation in the spirit and hope you can have the conversations in your groups in that spirit as well. We hope you enjoy the session and there is a lot to learn. Right, so what is the plan for us today? First of all, I'm going to talk to Breid and I'll introduce her in a moment about some of the key challenges that we face in new technologies and improvement. Then we want to bring that to life through two examples from Professor Alka Ahuja from the Anna and Bevan University and the Technology Enabled Care Centre in Wales, and Emma Vaux from the Royal Berkshire NHS Foundation Trust. I shall introduce them properly later when we get to that session. We'll then turn the conversation over to you in small groups, which I'll explain a little bit later, and come back to have questions and a discussion together at the end before final reflections. Right, with that, let us start. And first of all, I'd like to introduce you to Breid, who is the Director of Innovation and Digital Health at NHS England, and who is also a long-standing member, collaborator, and supporter of the Q initiative. So it's delightful to have you here. Breid is going to help me run the session today, apart from the conversation that we're going to have. And so we thought before we go into the details of the topic, we warm each other and all of us up a little bit through a short icebreaker in the chat. Breid, do you want to take over from here?
Yeah, hi, thanks, Malte, and delighted to be here today. So the first thing we'd like to ask you as a group is if you can tell us which town or city you're joining from. So just pop that in the chat, because really eager to know where we've got coverage from across the country. Oh, and they're coming in thick and fast.
There's awesome diversity there, I see. Great. I'm going to add a second one for the session, and you've joined to you because you're interested in technology and you're interested in improvement. What's the one bit of advice you'd give from some work you've been doing in the space that you'd like to have known before? Time, collaboration, resilience. Sounds familiar. Networks, patience. Complex systems. Process trumps good ideas. Yes. communication, collaboration. Great. Breid, do you want to do the last one?
Yeah, and this is maybe a bit more fun and less relevant, less specific to improvement in digital. What would your superpower be? What would you like as your superpower? Mine, for example, would be that I could be transported anywhere in the world without using carbon credits. Now, I'm very ambitious on technology, but that's probably a step too far. But yeah, what's your superpower? Or would you like it to be? Wow.
Talking to cats, great. Talking to animals, always having ideas. I wish I could fall asleep whenever I want to. That'd be great. I would never be tired. I could just have cat naps every time I want to.
That's a superpower I actually have, Malte.
Great. Someone also just said they have that superpower. I'm very, very jealous. Very jealous. Time travel, Andy. That's a dangerous one to pursue. Time and opportunity teleportation. I did like, Breid, that your superpower came, environmentally sustainable for transportation. Very, very good. All right. Thank you so much. Thank you so much, everyone. Let's go into the conversation. So as said, first of all, Breid and I are going to have a bit of a conversation about some themes that Breid and I have explored previously between digital technologies innovation and improvement around that, and get a bit of a sense of how we're thinking about that hopefully sets an interesting context and questions for you later. If you have questions now, feel free to put them into the chat. Though, as said, after you hear from Emma and Alka, we will have smaller group discussions where you can explore those, and then we come back to questions towards the final third of the session. So what I'm going to do is I'm going to set Breid sort of a few themes or questions and let her respond for a conversation. So I'm going to try and provoke a bit of thought there from Breid in that as well. So starting out, first theme, improvement and technological innovation. Do the two really fit together? So what I mean here is that there's quite a lot of conversations, it seems at times, going on across the NHS, where on the one hand, we talk about improvement, and on the other hand, we talk about innovation and technology. We talk about disruption and external influences and change, and we talk about iteration and optimization of processes. We use different language about startups and UX in one areas and PDSAs in other areas. And sometimes there's even different teams. There's a director of innovation and then there's a director of improvement in the same organization. How does this fit together? So Breid, is this helping or hindering us?
So it's a really good question. It'll be really interesting to hear what people say later on. So I'm going to start by just saying the simple definition for me that I'm taking of improvement and innovation, just so for context. So improvement being a thing that makes something better or is better than something else, just as and then an innovation is a new method, idea, or product. So if we take those two, I think we mix and match and we constantly conflate the two in healthcare. Is that a problem? I don't think it's a particular problem, but I was at an international conference last week, and someone said, we seem to honour the people who think of something new, but don't always honour the people who copy something that works. And for me, we need to be careful about what we incentivize and what we sort of show we value, because I think both are really important. So if I take how I think they conflate, and it's a positive conflation, is you may have something that's introduced that's new, that's innovation in one part of a system. And it's really, we celebrate, there's accolades, etc. But then when somebody in another part of the system scales that and rolls it out, it's still really new for them. So culturally, relationships, everything, it's still really new, but perhaps we don't celebrate that in the same way. So I think, we need, both are important and both could be defined as innovation from an individual's perspective. But if we're talking about it as always being something new, then it's not. So I think for me, we need to think of innovation as not just the thing, but actually the process and the people involved in its implementation. And that's where I don't think you can do it without improvement science. And Malte, you touched on something that's very, and Joe and others will have heard me say this numerous times, language is so important here. Because I think, similarly to, and colleagues going to speak later may disagree, but Similarly to specialisms in clinical care, sometimes we become so uber specialist and we use such specialist language that we manage to alienate people. And you mentioned some of this, but if I think of software development and technology, we often talk about agile, particularly around software development. And it was a really eye-opening for me to run an agile process in an acute trust around how we manage beds and flow, and worked with a software developer that developed with us. Because that is about testing and iterating, deciding on your scope, agreeing, testing and failing fast, and then moving on. But we use specific language around that as well. Whereas maybe an improvement person might talk about PDSAs, but actually we mean the same thing. So there's huge commonality, but by using different language, we often alienate colleagues, or we may, rather than drive sort of coalescence around a common problem. So I think the role that we today, or anybody, there's a couple of things, I often find myself working as a translator. And I do call out where I think people, because I think it does still happen, but not so much, where people use specialist language to retain power, because that's not collaboration. So I think we need to call that out. We need to translate and come down to simple language. And that's the way we will bring the two worlds together. So then it really is a shared endeavor, because I don't think we can keep them separate.
Yeah, quite right, Breid. I very much agree.
You're mute.
Can people hear me?
Yeah.
Yeah. Okay. Great. I very much agree, Breid. I spent the 2 years before joining the Health Foundation working for a startup, for a software as a service startup, so very much in the technology software space. And I've always found it fascinating how particularly the product teams and the software developing teams are talking about significantly rapid iterative user testing, and how they use that to constantly adjust the functionality, for example, of an app, and how similar that is in principle to the idea of iterative cycles of testing, knowing what works, engaging really closely with the direct user of an idea or a process or an app in this case. But how often actually the sort of the commonality doesn't get explored, and it sometimes makes me wonder whether we could do more in learning from each other in that space. So how a software developer will do user testing and how we do iterative approaches in improvement. Do you think there's opportunities to bring those two worlds together more and in learner approaches?
Yeah, there's two things. I think for me, that's one of the areas of commonality between, I think, the technical world and the improvement world, because we both talk about user engagement, user-centered design, service design. So I actually think that it's already happening, but perhaps we still probably in the NHS are skeptical about deep supplier relationships. We need to build strategic alliances and strategic partnerships with some of these suppliers, but that's quite hard when you think about procurement rules and healthy competition. So I think we're gradually becoming a more intelligent consumer of technology in the NHS, and I think that with that we will become a more strategic partner. So I can see embryonic signs that is happening, and I think we need to embrace it while still keeping a healthy market, because a healthy competitive market drives innovation from a supplier perspective as well. So I think we need to get both right. And I think just bringing it back perhaps to even relationships within organizations, very often improvement teams, and I've sat in both worlds, so it's not a negative to anybody, very often improvement teams may work with clinical colleagues, etc., come up with really good ideas, but don't involve technology or IT colleagues until quite late. And then suddenly IT colleagues are the ones who are saying, oh, you can't do that because of IG, or you can't do that because of your commercial. So they're seen as the blockers, but actually they have a regulatory responsibility that they could have picked up if they were involved from the outset. And ditto, I've seen clinical teams go to technology colleagues and say, oh, help me with this problem. Technology colleagues do something with them. It's sort of a darkened room. They get something and then it comes out, and suddenly there's a downstream impact on another clinical team that actually, had we had improvement in the room, you'd have understood that whole, the whole balancing metrics and really brought that to. So I just think we've got amazing capability in both tribes, and actually bringing those together, gosh, we could do just amazing things. And there are examples of that happening. It's not, but I think we could do more of that.
Yeah, and we may hear a little bit about how that could look like later. So to bring this theme together, I think a lot about understanding each other, collaborations, human relationships, which I think is very consistent with some of the lessons that some of you put up early on during the icebreaker. Breid, let me come to another theme or small provocation. So one of the other things that new technology has done for us is to generate more data, but so much more data that sometimes it's absolutely overwhelming, or it feels like a ride slog to get into that data because there is a fancy new electronic patient record and it just has loads and loads of functionalities, not where to start. So what's the right way of engage with that for an improvement practitioner to actually benefit from it?
Now that really is a difficult challenge, isn't it? Because we still have loads of instances where we don't have enough data to make the right decisions. And it was interesting because Penny talked something about earlier about what gets measured is often what matters, but very often we measure what's available because we don't have the right data. And I would say, in improvement worlds, we need to think about measuring what matters from the outset and defining what that is. But if I take our work with virtual technology-enabled virtual wards, we know that there are wearables out there that collect data every second. So colleagues describe this as the hosepipe of data that is suddenly complete. That's completely unmanageable, and nobody can consume that in a knowledgeable way. So for me, I think, yes, we want to collect data, but we need to then surface or present that in a usable way for patients or citizens, if you're talking about the health promotion agenda, and for clinicians to be able to manage, because I know that's a big worry for clinical staff, is that we're just going to have so much data that it actually stops us being able to make decisions, and the accountability, we're not watching it all the time. So I think we need to really think now, because if it's bad now, imagine what it's going to be like in 5 years. We absolutely don't want to stop collecting data, because we don't actually, some of it that we don't think is useful now could be amazing in the future. But actually we need to surface and present that and manage that in a way that is useful. And that comes back to, standards, clinical terminology. So we know, apples and apples, that when we say blood pressure in one system, it's the same in another, because that's a clinical safety concern. So interoperability, it's, there's lots of things we need to do in this space. And very often we focus on the data rather than how do we, the user interface with some of this technology, which is how we start to collect useful and good quality data. And then, as I say, the whole standards, the interoperability, and then how it's presented. So for me, this is an area that we need to give really significant attention to moving forward. And from an improvement perspective, we need to be able to present that to people who need it. And, we talk about test and iterate. Well, you need data to be able to say what's worked, what hasn't. So I think it's a great question, and it's a huge area that needs very significant focus.
And I think you're right, Breid, that so much effort at the moment goes into generating more data, making more data available. Actually, there's this big step still to be taken then with what is the most important data actually that can make a difference for us? How do we make it accessible and usable on a regular basis for the practitioner? And I guess also going into really understanding what is the data in the first place that will make a difference here. And I think there's a big opportunity here for the improvers in us to help our colleagues who are introducing the electronic patient records, or who are introducing the wearables, etc., and generate all this data, to help them identify, actually, this is the type of data, not amount, this is the type of data that would actually really help me in an ongoing decision to improve care. I'm often struck, for example, by how much we are talking about bringing data together in shared care records, particularly between health and social care, is a really big challenge. And at the same time, there's very, very, very little understanding what data from social care, whether in a care home or where people receive care at home, would actually make the biggest difference for care decisions across health and care, whether it comes to prevention, identifying risk, supporting people better once they come into NHS pathways from care. And until we actually understand what particular data would make the biggest difference, talking about bringing lots of data together doesn't really get us anywhere, because we might be combining data that actually doesn't help us very much in that.
Yeah, and actually reflecting on some of the chat from the previous session, which was all about people and human relationships, that data, it's not just about data, it's about trust, because people will only share data if they trust. And that's not just patients, but I facilitated an after action review from a health and social care teams that had combined a shared record, expecting it all to be about information governance and things. And actually what it was about was trust between the clinicians and the social care staff, because some of the clinicians didn't think some of the information should be shared with social care because they didn't understand how social care utilise that, and vice versa. So I think, data, we talk about data as a sort of logical, structured thing, but it's data in terms of how it's collected, how it's shared. The people and process is a huge part of that as well. So we should always try and make sure we don't lose sight of that.
Yeah. Okay. One more theme.
You're on mute again.
Oh, can people hear me? Yeah. Okay. One more theme then before we move on to the next session. The question of equality and technology. So for some people, new technology are a huge opportunity for us to address equality and inclusion and how people receive care and are involved in their care. For others, it's seen as an incredible risk of making exclusion and inequalities worse in how people receive care. Who's right?
I don't think we can say this is right or wrong, because actually it is, the growth of technology during COVID has been phenomenal. I mean, I've worked in healthcare between improvement in digital roles since 2003, and I've never seen anything like the pace of change in COVID. I think it's something and it was touched on again previously, this whole idea of the user voice and co-design needs to be, we need to design for the minority, and then we will include the majority, if that makes sense. Now, that doesn't mean we shouldn't move ahead with something just because some people can't access it, because that would be wrong as well. So there's always going to be a tension. But I've heard, examples during COVID of where actually GPs thought that remote consultations were actually enabling them to interact better, particular video with some patients, like someone who's deaf, because you can have a person doing sign on the screen, whereas they couldn't do that with a phone, so they'd have had nothing. But I've also heard people say, well, actually, because of digital poverty or connectivity, we're excluding a group of people, and we need to address all of those things. But it doesn't mean we shouldn't offer the service to whoever can use it, because we have a huge demand profile in the NHS at the moment and in the care sector. If technology can help manage some of that more efficiently, we should absolutely embrace it. And I think we need to concentrate. People talk about hard to reach. I hate that term, because they're only hard to reach because we haven't used the right approach to reaching them. So I like to think about the seldom heard voices, and it's really important when we're doing user-centered design that we have those seldom heard voices, and we have people really challenging. And that's both clinicians, like it's the user voice more broadly. So patients, carers, citizens, if you're talking about health, the health and keeping people healthy agenda, and clinicians, administrators, whoever. We really need to think, what does this mean for somebody? Because we can also exclude staff, because, in the care sector, we know that people, digital maturity is not so strong. In fact, somebody told me last week in this conference, there was a shocking, it was in Europe, it was a Europe stat, and I haven't had a chance to check it, so I'm saying it with caution, but 15% of adults have limited literacy skills, 20% of adults have limited digital literacy skills, and 40% of adults have limited health literacy. So if you put all of those things together, we really need to think about how we design and how we communicate and interact with our communities.
Yeah, thank you, Breid. I've also always been thinking how much support there is to new technologies around a lot of the requirements that we expected to fulfill, like data protection, safety, etc. And actually, technology companies can go to loads of places to get advice, whether for free or paid for. Actually, if it comes to designing for equality in technology, there aren't that many places to go to. And it also feels to me there's something we can do maybe to encourage this as a marketplace and an incentive for that. Of course, the companies have their own responsibility to do that well, but also how can we create an environment where there's no excuse to not do that well.
And I think linking to the work that Bola and others have been doing in the Core 20+5 agenda, really making sure suppliers and others are aware of those sort of initiatives within the NHS and care sector is really important, because otherwise they work in joyful isolation of perhaps some of our inequity challenges.
Yeah. Great. Okay, Breid, thank you so much for your reflections on these three topics. So let's turn to hearing from two Q members who've actually tried to address these in real life at their work. So let me introduce first of all Emma Vaux, who is consultant nephrologist and general physician at the Royal Berkshire NHS Foundation Trust, and she's going to talk to us in a moment more about some work she's been doing through Q Exchange. And secondly, Professor Alka Ahuja, who's a consultant child and adolescent psychiatrist at the Anna and Bevan University, and also the National Clinical Lead for Technology-Enabled Care in Wales. And she's been working on a project through the Q Lab. I will allow Emma and Alka to introduce themselves in a moment, and then hand over to Breid to ask them some questions about their experience. Emma, if I can start with you to please introduce yourself, say a little bit more about your project, and then hopefully we can also see a short video about it.
Lovely, thank you. So I'm Emma Vaux, I'm a nephrologist in Reading, and we designed sort of transformation of our outpatient services back in 2017 and kind of went live in 2019. Fortunately, all nicely ready for when the COVID pandemic came along. But during that, we recognised the opportunity for the need to build in the capability for people with chronic kidney disease so they could better understand and self-manage their condition. And that would be through the use of modern immersive technologies. So we work with patients and with wide-ranging healthcare workers and with a company called Cognitant, and developed an app-based, avatar-led, interactive digital program. And this was piloted, was really well liked, really did seem to help understanding of conditions, and people felt better able to self-care. So we then proceeded to translate into 4 other languages, and very much with a focus on reaching those where languages can be a barrier. And this was not just translating into the languages, but using culturally appropriate avatars. And it's now in a widespread launch, and we're doing the same for acute kidney injury next month. So just wanted to show you a flavour here in a short extract of a video.
Emma, thank you so much. Alka, if I now turn to you to introduce your project, and I think we'll see another short video after that.
Hi, thanks, Malte. As you mentioned, I'm a child psychiatrist based in Anna and Bevan, and the work we've been doing is TERMS, which is technology-enabled remote monitoring in school. Obviously, as a child psychiatrist, schools play a huge role in what we do, and we know children and young people spend a lot of time in their day-to-day life in a school setting. One of the challenges we've had in mental health, which was even before COVID, was the increasing demand and the limited capacity that we have. Although there's been a lot of initiatives, but how do we deal with this? And COVID has not made it any better. So we were working with young people, education, health colleagues, looking at how we could deal with some of these challenges, especially around young people with eating difficulties. So this ranges from those with fussy eating to right to the full-blown anorexia, ARFID, which is avoidant restricted food intake disorders. And it's interesting because we've been working across different teams, and the schools absolutely came on board. The young people loved it. What we have developed is, again, I can't resist myself. I call it a windscreen model because we go that, and the young people love to do that, is looking at what technology support is required right from the basic side where, young people may just have difficulties, and a bit like what Emma said, what can be done through apps, websites, going into, virtual groups, virtual consultation, and then the end, which would be about remote monitoring, looking at their blood pressure, pulse, vital parameters, without needing to miss school and attend an appointment. And often these are the most difficult people to engage with. And I totally agree, Breid. It's not the ones who are difficult to engage with. I think we probably need to do more than saying that we just give up on them. So happy for you to share the film that we have developed together with the young people.
Technologies. And then came a crunch point, testing our prototype with the young people we were so keen to help. There was a lot about it they liked, but they told us in no uncertain terms what parts they did not like, and we listened. There were certain elements that we had seen as non-invasive, but our young partners disagreed. They were removed. We refined our prototype to fully reflect their feedback and how right they were. Together, we developed a windscreen model. This model allows the intervention and support for the person in question to wax and wane according to need, without an assumption of the start and end points as with the earlier stepped model. The technologies will include wearables, school-based monitoring systems, and virtual links. We have developed dashboard designs suitable for different settings and populations.
Fantastic. Thank you so much, Emma and Alka. Breid, if I hand over to you to ask some questions in a conversation with Emma and Alka.
Thanks both. Really exciting projects, aren't they, both of them, and quite different. If I go to Emma first, Emma, I love the visuals and the iterative, piece. How important do you think they are in terms of, and the use of avatars? How important do you think that is in engaging people? And then sort of aligned to that, one of the things I meant to mention earlier is I think we have a bias as clinical staff sometimes in who we offer things to, because I hear people, in fact I heard it at this conference last week where somebody said after 65 the use of technology really takes a nosedive, and I immediately said I disagree, because I think we have to be careful about our bias. So it'd be interesting to know how much the visuals bring and engage people, and then whether there's any bias that we need to address and who it's offered to.
So I think our standard usually is a written patient information leaflet that may have appeared lovely and glossy and colourful at some point in its life, but through NHS iteration is usually reduced to photocopying on a piece of grey paper. So that often loses a lot of its impact. I think visual is so important. I think we can't underestimate health literacy, and where there is a language barrier, bringing it to life with visuals can make a huge difference. This is translated into Polish, Urdu, Punjabi and Nepali, because those are our 4 top languages other than English in our area. And so I think the combination of visual, that it's a spoken, but there is also the written option as well, because it is important. Some people still like written information. Not one model fits all. Every person is different, and some people like a combination. And I think it's being flexible and responsive. And I think we could probably do even more in terms of how you can help people engage with their condition. And certainly age, I would agree with you. And perhaps the more mature person also has grandchildren who are very digitally literate. But to be honest, most people reach out their smartphone from their bag during their consultation, will have looked up things before. And so this is a way that being more proactive in helping them engage in the right way and perhaps navigate through the wealth of what can be really often difficult to understand, or what is the fake kind of information about their condition. So the more we're proactive in helping them, the better.
Great, thank you. And Alka, I have to admit, I have heard about Alka's work before because they're part of our Q Lab program, and very inspiring. But one of the things, you talked today about wax and wane rather than a step model, and I think that's really interesting because we do lots of work with long-term condition management, and actually we do talk about stepping up and stepping down. And perhaps you've made me think, perhaps that isn't how people really want to interact with healthcare. And there is maybe that wax and wane idea is something that we need to think about more broadly. I just wondered if you wanted to say a little bit more about it.
And again, we first started with a step model because I think that's the temptation when you think about health conditions. But the beauty of working with young people and people with lived experience was, especially in eating disorders, they thought it was getting too precious, and everybody would then aspire to go to the top to get the whole package, the Rolls-Royce package. And we do know that with young people, things fluctuate depending on social circumstances, depending on what's happening in school, in their personal lives, academically. And often it may be that fluidity that's needed, and for us as clinical teams to flex up and flex down. And that's when they suggested, can we have something where, sorry, I keep moving my hands. Can we have something where we can move from, the low end, where we do know a lot of young people with autism spectrum disorder, because of their sensory issue, may have fussy eating, but they may not necessarily have the service that is offered by an eating disorder service. And that takes me back to your question of us becoming too specialized and sort of confining ourselves to only these people that we will see. Whereas you then have, the anorexics who are full blown and would need everything that is on offer, including maybe an admission to pediatric ward. But as they get better, it may be that they go on the other side. But again, there may be crisis, and it's having that ability to cater to individual needs other than putting people in boxes and saying this is what is available because this is what as a team we do.
Sure, Malte's got some questions. I could ask lots more, but I should share the opportunity.
let me ask you one as well. So you both showed through the videos really impressively how you've used technology to reach people in a different way. So I wanted to ask you, first of all, what has the experience been like for you to work with a technology partner, a software developer, to put this forward? What was that experience? Did you recognize any of the tensions we explored earlier on? If I start with you, Alka.
Okay, it's interesting because, again, a lot of what you were saying, we were resonating in terms of language and communication, because it was, young people, mental health, oh my God, information governance. But we are clinicians, we deal with safeguarding day and night, and it's very similar. We would have those red flags coming up. And I think sometimes it's putting the cards on the table and telling people this is what we are aware, and we would be taking those sort of precautions. Again, having those open dialogue with school and education, because we very early on realized the firewalls in education schools often don't marry the firewalls in the NHS. And whatever you think would be fantastic and would just fly with, it just gets crashed at the worst instance. So having those conversations as to what data is really necessary, because people do get very precious about data. I get very excited. I'm an academic, I love data, but then what is that is needed from a clinical point of view? What is needed to make a difference in that circumstances, and how we can be sure, in be it an information governance framework or be it in a safeguarding setting, that will be needed for this particular young person or child. I think more than the technology providers, unfortunately, it's the clinical teams that have been a challenge. So, I can go on talking about that, but I think it's, again, that resistance, and why do something different, because we are just overwhelmed, just put our head down and continue doing what we are doing. So I do think it's having that open mind, because we can just continue doing more with what we have unless we don't change.
Yeah. Interesting. So again, the point of openness and building human relationships to overcome some of those barriers, rather than anything intrinsic to the processes or approaches or technology itself, that creates the challenge. Emma, how was it for you in the teams developing the technology as part of the project?
Well, it's certainly expensive. So I don't think that should be underestimated, how much these things cost. So having the investment to start the development was hugely enabling from the Health Foundation. However, you then have to think about sustainability costs. So it's not just the licensing, it's the operating costs. It's also important to think about the intellectual property, information governance, on it goes. I think one of our big learnings, so I was asking Cognitant from their perspective what their learnings were as well. And I think we started through an app approach, because that felt the best way forward, and certainly when we started off, it wasn't just written immersive 360, but we also had virtual reality, and I was sending out virtual reality headsets to all the patients. That wasn't necessarily a sustainable model. And in fact, looking at accessibility, starting with a web-based delivery is probably the better place to start than starting with an app, unless you're looking for gamification or virtual content requires that app build. I think the other is that the world of translation into languages, one of the things is that not necessarily familiar with. For example, Urdu is a much slower spoken language. So if you have your animation designed and you then have to adapt that with a much slower dialogue, you will then need to adapt the animation for those transition periods. So really interesting in terms of where do you start, and certainly I guess it's always trying to think 10 steps ahead. What is it that you will want to be doing so that you think about how you will adapt as you go? But one of the biggest things was engagement of patients. So that was with Cognitant, with us, and patients enabling huge insights into the program. So it was useful and of value. There's nothing, we're so good. I think, I've been a doctor for a very long time, but I think every quality improvement project usually involves how do you improve warfarin prescribing or something like that. There's always a checklist. So apps seem to have become the sort of version of the digital checklist, and we're in danger that where these digital solutions are not necessarily streamlined, that they're just another add-on that makes the whole flow of the patient care and information more stuttering, and sometimes can feel in competition. So that how you have patients helping to build right from the start, but thinking of your stakeholders and what perspective and lens do you need to look through, has been incredibly helpful.
Fantastic. And I was really impressed by both of your descriptions, how much it brought together the technology side of user testing with really understanding what the needs are of your care recipients or patients, and connecting that. One last question before we move on to the next session in a minute to both of you. If you had known one thing before you embarked on this project that you know now, what would you have done differently, Alka?
Time. I wish I had more than 24 hours in a day, because these things can be very time consuming. And when you are a jobbing clinician, with the best will in the world, you are trying to do these things in parallel. And often when you've got people at different levels that you're working with, because I think it's having that systemic approach. We've got health, we've got education, we've got third sector. People have different agendas. And going back to your previous question, I was just remembering we did a piece of work on developing an app, and the digital providers were keen on putting pop-ups there. Now we work with very vulnerable young people. For us, it's delivering something that's going to be clinically safe for them. They're going to be tempted to click on this. So I think it's having those similar agendas and singing from the same hymn sheet and having patients at the center of it. So I wish I have more than 24 hours, and I wish I could do much more than what I do.
Well, we definitely appreciate everything that you're doing, Alka, as part of this. Emma, the one thing for you?
I guess with the ever-changing NHS landscape, how integrated care is translated into integrated care communication models. So you can develop things, but it's really tricky to get it to where you want it to be, how it reaches in the right way. And I think so when we keep talking, I have to have faith that these new integrated care pathways and systems are going to do what is intended, but at the same time we need to have better ways of our communications to go alongside, so that all the amazing stuff, that there is so much amazing stuff out there, actually reaches where it needs to.
Yeah, great. Thank you so much, Emma. Thank you so much, Alka, and thank you most of all for all the work you've been putting into this project, but also having such an honest and open conversation with us as part of this session. Really, really appreciate it and grateful. Right, we've got to move on to the next session, which involves all of you having an opportunity to reflect and talk about what you just heard, what it means for your daily work, what questions does it raise for you. Now, the approach we're going to take to that is from our liberating structures approach, and it's called 1, 2, 4 all, which means that we, in a moment, through the magical powers of Zoom, are going to put you in a conversation of 2 people for a short exchange about what questions this raised for you and implications for your work. We're then going to move on after 2 minutes from those pairs to join another pair, so there'll be 4 of you, where you have a slightly longer period of, sorry, I actually got this wrong. So you've got 2 minutes to reflect by yourself. Then you've got 6 minutes in a pair. Then we're going to take you to 4 people in 2 pairs where you've got 9 minutes. And then we bring you all back together. When we're all back together in the room, Breid and I are going to ask you to reflect back 1 question from your discussion to the speakers, including Emma, including Alka, including Breid, and including myself, of course, and have a conversation. Right, let's hope this works. Let the magic of Zoom commence. 2 minutes to yourself, then we're going to put you into a pair. This can feel a bit abrupt when the screen suddenly changes. If there's any issues, please contact Ponima or Adriana, and we'll make sure you're in the right room or space. All right, talk to you in about 20 minutes. Okay, welcome back. I hope you've enjoyed those conversations and it worked well through Zoom. We'll have a brief evaluation at the end where you can please give us your feedback. Now, we had 5 groups just now for discussions, so I'm gonna pick on each of the groups to ask a question for our speakers. I'm going to start with room 1, so I'm now putting those guys on the spot. Andy, Dan, Jackie, and Jen. If one of you wants to hold up their hand or ask your question, please go on unmute, or if you put up your hand, I can see that as well. Who wants to ask from your group? Who dares? Otherwise, I will pick on one of you.
I think it was me.
All right, Andy. Yeah, go.
Yeah, and I'm going to try and articulate because it flowed very easily in the group, but may not here. We discussed a lot about how there's lots of frustrations and lots of reinvention in the market as it stands at the moment, and both people developing technology and people using technology. How can we get past this stage? It feels like it's an immature way of working. We need to get to a stage where we can do the local tailoring and we can do the local adaptation, but it's expensive, as was said earlier. So how do we leap past this? There's good dissemination of best practice that doesn't stifle new innovation as well.
Thank you, Andy.
Did I get that right, team?
It definitely sounded like a very good question. Breid, can I maybe point that one to you to start with?
I think it's a really good question. And, if we start with the fact that, any health or care spend is public money, value for money becomes really important, as well as, I think, the frustration of people making the same mistakes that could have been avoided because somebody's already made them and learned from them. So if I take the example of the virtual ward work at the moment, I'm really heartened by the fact that we have meetings every week, which are open to anyone from an ICS. So it's an ICS level meeting, but we have provider colleagues join as well. And people, it's not the centre talking to people. We do sometimes, but actually it's bringing the stories from the ground and it's really sharing that learning. And just as you guys were talking, Malte and I was commenting on the recent Health Foundation publication on learning health systems. And I think, much as I don't want to put another name on things, actually trying to use the building blocks that are in that paper, because I think that's what we're doing in the virtual ward work. Not that we've done it from we must create a learning system. We must enable. I think the role of the centre is to help people to collaborate and share learning. We can convene people. We shouldn't be telling people what to do. As ICSs emerge, we need them to be able to manage their local systems. But I think that convening and getting people to speak to each other, it's interesting commercially on the costs, because again, sometimes we focus, I think I mentioned earlier, I think we're becoming more of an intelligent consumer of technology. We've got a way to go. If we need to start from a requirement specification. What is it that you need from technology to enable your service to flourish? And being ambitious, so you don't sign a contract for technology now that actually is going to be obsolete in a couple of years' time. So really trying to bring in colleagues to help with that ambition, but then also looking to who is using the same technology across the country, because you can reach out to other people. We don't get that confidential commercial information in the centre because people sign contracts directly with suppliers. But you can go and talk to colleagues who are already using that. That's the way I think that's what, if I was buying something myself, I will go and talk to someone who's got that car. I will go and find out all the pros and cons, and I will think, oh, this is a better price deal than I'm getting. So I think getting people to share learning and then to also collaborate and talk about some of the commercials, I think is really important. I don't know if that's answered your question, but they're just some initial thoughts.
Well, let me come to Emma as well, if that's okay, because we just, during the breakout briefly talked about that, also thinking about how you can spread the approach that you've been taking locally. And what does that feel like at the moment to actually look at spreading this more widely rather than just doing it locally with your partners?
So I guess, I'm probably grounded in reality in terms of what this looks and feels like. So the so what piece is really important. So you can say that your piece of work is doing this and patients like it and it's received positively, but the so what for me is, so what difference does that make in terms of outcome and experience, and how can you measure that? So fortunately, that's a piece of work that we're doing with the University of Reading. That becomes more compelling argument, I think, for providing evidence for others to want to scan and spread it themselves. There is no doubt, and I think it was Andy who commented about the bespoke piece, what's developed. We couldn't even get people to share patient written information leaflets. It was all about how do you bespoke it for your area or condition. But you have to be thoughtful about the licensing and the on costs. So in terms of, we're looking through the UK Kidney Association, through Patient Knows Best, which is another way of another company in terms of sharing information about conditions and patients being able to look at their results. So it's connecting into the systems that are already there, providing the opportunity for other providers to be able to bespoke and how they may use the things that you've already developed. And you do have to think, I know there's the money bed there, but the money is important when you're thinking about sustainability of these things. There is no doubt there are ongoing on costs that have to be thought about. But if you can think about it so for us, we've invested huge amounts of money, very fortunately through the Health Foundation, but also our local our renal charities. So this is really our patients who are supporting information for patients, and that's the best it can be. But then how for others can, if they can annual license for £2,000 a year, that cost is so much lower than if you're trying to develop things right from the start. And thinking about how can you connect through third sector as well. So there's no doubt patient charities are hugely influential in being able to share the goodness that's out there of things that are developed. So there's something about openness, willingness, but there is no doubt you need the supporting infrastructure to make it work for these things to scale and spread.
Alka, if you come in, and then I'll take the question from room 2.
No, I was just going to mention, because obviously we're looking at one for Wales at the moment, and going back to the discussion about talking about successes, we've developed a project register. Happy to share details about our website where we talk about successes but also failures, because there's so much learning that can happen from what's not worked, along with details of the person doing it. Similarly, I think like most places, we've got pilotitis. We start with a pilot, people move on, funding runs out, but what are the lessons learned and how do we capture that? And lastly, we're linking in with other places. As you said, Breid, we've got an event on the 16th of November. Again, happy to share details with the University of Toronto, because Canada, again, like Wales, have been doing telehealth, telecare for a long, long time. What is that we can learn from them and adapt and pick it up and use it, other than trying to reinvent the wheel?
Yeah, I really like your point, Alka, about sharing not just what works, but also what hasn't worked. I'm reminded that in Scotland, there's been an attempt to look at innovations from the perspective of how spreadable it is. They call it a spread assessment, and it actually looks specifically at how local is the context, what are the specific circumstances of a change or improvement, and does it lend itself to be replicated elsewhere? And in some cases, they would say, no, it's so specific that you can't just do it elsewhere, or it would be a huge effort, and it doesn't lend itself to roll out elsewhere. So I think there's a lot we can do in that space. Let me come to room 2, Bruce, Christine, Horace, and Libby. Does one of you want to ask your question?
I can jump in if no one else is.
Go on, Libby. Thank you.
We didn't completely get to one question, so forgive us for some of this, but we spoke a bit about the, it felt like Emma and Alka both talked really well about how your projects had listened inclusively. And we wondered a bit about what helps you to do that. Did you miss people out? How did you respond to it and iterate it to make sure that you were, throughout the work that you were doing, involving the right people? And we were also reflecting a little bit about the challenge from Mary in the first session about how to design at scale and customise locally, and wondered how, if you had any reflections on the tension of both being able to listen inclusively with your local communities and also considering the scale question, and just how you may be reflecting on it, which maybe speaks a bit to what you were talking about in the last answers.
Great. Alka, do you want to start?
Again, it was very surprising because we thought people would be reluctant to talk about mental health and eating difficulties. So when we first started, we started with a smaller group. But the moment we went into schools, to our surprise, young people are willing. And in fact, we were first introduced to the school council, and these are sort of the brightest of kids. But we said, can we talk to, sort of the average, the normal kids? And again, I don't know, we talk about eating difficulties. It's surprising what a couple of Domino pizzas can do. And we had people queuing outside. We went with 100 printouts. We had to, in the end, print out 550 sheets to get the feedback. And people are there willing to, indulge in these sort of conversations because they want things to be better for themselves, not for themselves, for their peers, and as mental health conversations are much more openly happening in schools. I think schools are quite open to having those sort of dialogues. So it's just having that time to engage with people, and our people are willing to, contribute and have their say.
Great. Emma, and then I come to room 3.
Yeah, so it's always interesting when you're developing patient information, and certainly we're very fortunate. We have very amazing patients who will come forward and get involved. However, what was suddenly realised was that the important thing here was not necessarily concentrating on those people with chronic kidney disease, but how this would land with people with no this was completely new to them. This was a new diagnosis. This was a whole new difference. We talked about language and how people talk about what was wrong with them. And so that was really important to spread in terms of who you're looking to look at the material. We're very fortunate at the Royal Berkshire Hospital. We have amazing patient leaders who are sort of informed and trained and come alongside and ask very thoughtful and tricky questions. I think Tim is I've spotted seeing him, and it's really, they come huge different perspectives, and again it's looking through the lens of lots of different people. So I think it's a bit of that balcony view. Stand back and think about who are all the stakeholders, and that not just think of the usual ones that you reach out to, but the wider fields, and how can you enable an opportunity for them to get involved. Word of mouth becomes a really important bit, and speaking with the dietitian and the pharmacist and our primary care colleagues, they're able to hook people into. We started, I think we got our Health Foundation funding in November 2019. Our project plan went live in February 2020, and then of course COVID, but we still managed to continue and deliver and do everything we wanted to, despite, oh my goodness, everything else that was going on. But part of that was the different ways that people could engage. So it wasn't always just face to face. It could be a telephone call. So adapting the way that you engage people to enable that flexibility and allow people to engage that the way that they want to is also important.
Thank you so much. All right, room 3, we've got Karen, Michelle, Rebecca, and Sally. Would one of you like to share your reflection and question before I pick on one of you?
can do it.
Okay, Michelle, great, thank you.
This is Rebecca. I thought summarise it quite well. So we were talking about the challenges. I don't know, this kind of, I think, crosses over with what other people are saying, the challenges of, you know, how we sort of make time for staff to, you know, be involved in the projects, and how we get that level of engagement, and who we need to engage in order to get things moving. But I think it was really a question around, you know, what was your experience around, you know, where clinicians are really hard pressed for time, to you know, to get them to recognise the importance of this, and how did you support them in making that time, really? What was happening in your organisations to support them making that time? I know you mentioned that you wished you had more than 24 hours a day, and I think that we're trying to get clinicians who perhaps we're trying to get buy-in, and when they're under that massive pressure.
Thanks, Michelle. Alka, do you want to talk about that?
I totally agree, Michelle, and it's just being opportunistic, because we've done all sorts of things. We've sort of bought a slot, when I say bought, you know, sort of tried to get our way into consultant away days. We've done team meetings. We've gone at lunchtime with coffee and cake, which is often quite, you know, helpful. I do believe a lot in fika, and this was a principle I learned at one of the Health Foundation meeting, where, you know, if teams eat together, they tend to be more productive and receptive to things. And I think, you know, that has worked. And, you know, sometimes we've even gone out of hours and looked at teams that are working, you know, our crisis team, and tried to engage. So that's why I think if I had more than 24 hours, I could do more of that. But I think it's just finding the right opportunity and grabbing people wherever they are to make those conversations.
Yes, success goes through the stomach, doesn't it? To make it happen. Absolutely. Right. What I'll do is I'll take the questions from room 4 and room 5 now, and then respond to that, so we make sure we can wrap up at 1:45. So room 4, Danielle, Dave, Jenny, Sebastian, and Sorab. Does one of you want to ask your question, please? It's a great little game of dare, isn't it?
I think I'll step forward, be brave.
Go, Danielle. Thank you.
I think for me, I'm on the other side at the minute of a lot of these digital innovations which are coming through the academic health science networks, and we're being asked to review them. And I've got my QI hat, but I feel like digital has a whole nother layer of ways that you should be challenging it with regards to, for example, GDPR and licensing. Where does the money come in? Like, how are you going to maintain it? I was just wondering, do you guys have any good frameworks? Obviously, there's all the good QI frameworks, but I feel like they almost need another layer for digital.
Great questions. All right, let's hold that. Get the question from room 5. That's Jam, Rachel, Ruth, Sarah, Tanya, and Tim. One of you put up your hand or step forward with your question. Or I'll pick on one of you. All right. Jem, you turned your camera on. Go for it. Thank you.
Oh, that was perfect timing. So I think part of the reason why we haven't asked questions is we probably didn't focus on the question, as it were. I think it was more of a commentary and discussion about different challenges. And I think one of the ones we talked about was about you know, having the space to do things well. And I think the challenge of being rushed versus to get it done versus being given the time and space to do things properly. So I think it's similar to Michelle's question, which was around, you know, how do we make sure we're creating space for people to engage in this properly? It's really hard to do this stuff well. You know, you need to create the want for people to engage in that conversation. You need to have the right technical expertise to avoid going down those cul-de-sacs of, you know, you're not allowed to do it for IG reason, or it's not technically feasible, or whatever it might be that you end up hitting down the road. So I think there's something about the leadership that's needed to enable this to happen well, and it's not easy. And is there anything that you can advise in terms of for leaders in organisations who are trying to lead digital innovation? You know, what sort of tips are there? I guess that would be. I don't think that's what we discussed as a group, but I think that is that reasonable enough as a sort of summary.
Yeah, thank you, Jim. You've got, you know,
conversation.
You stepped up, so you got the license to shape the question. Absolutely. Emma, Alka, if I ask you both to do sort of 1 minute on that question of leadership and sort of tips, and I come to you, Breid, on the question of whether, is there a framework around that helps with the digital on top of QI and the maintenance of it, and then we'll close. If there's any further questions, please put them into the chat. Also, if there's anything particular you'd like afterwards to hear from Breid or Emma or Alka on the specific work, please put it in the chat or get in touch with us and we'll make sure we connect you. But over to you, Alka, for 1 minute, then Emma for 1 minute, and then Breid on the framework before I wrap up.
And Jen, there's no quick answer, but I would say it's a multi-pronged attack. It's fortunately in Wales, we've got a lot of support from Welsh government, so that always, is helpful. But even starting on the ground level with clinical teams, we've employed a lot of research assistants who are working and embedded themselves 24/7 in these teams. We're working with trainees. Again, they seem to want a QI project or a research project or audit project. So is there something that we can give them and in return get their time to work alongside the teams they are working with? We've got medical students. In fact, we've just got our first digital fellow appointed by HEIW. So I would say wherever you have an opportunity, get people on board, start singing from the same hymn sheet, and then it will disseminate. It is going to spread, but it's just sort of getting the right people there.
And the social movement, isn't it, Alka, that you can establish? That takes patience, I'm sure, as well. Emma?
So it probably helps I'm clinical lead, but also clinical director. So there's something about time for staff. If it's seen as important and you have a compelling vision, it's understood by others, then it does become part of how you build it into business as usual with your service improvement agenda. Where it has synergy with so many other issues, that's a really good way of connecting in. And that this is another way of meeting the priorities that you have. And there is no doubt, there's a real joy. There's something about bringing a new energy to the ways that you work, where you've got people who are coming together to look at something differently. So having that, and it doesn't have to be long periods of time, you just need to be methodical about how you do it. So having a project plan and management, clear actions and responsibilities, that you're very clear about how it's going to work, who's doing what, and keeping those regular meetings in the diary, that continue momentum. Everyone has so many competing demands, but if you have that core supporting infrastructure, that's the bit that I think really helps to unlock it, but also to come with your eyes wide open. There is a degree of naivety. Everyone's going, oh, there's digital solution, but forget that that company might go into administration. What's happening about the intellectual property? Have you done your project impact assessments? What's the health inequality impact? What is the money and what is the sustainability way that you're going to keep that app going? It's not developing something shiny and new that you can then just show everybody how amazing. It's about shiny and new that becomes business as usual over time and hopefully used by others too.
Yeah, thank you, Emma. Breid, over to you for your last reflection, including on the framework question.
So I've just popped in the chat the DTAC, link to the DTAC, which is the Digital Technology Assessment Criteria, which is the regulatory requirements. It's more focused on the supplier, but actually, a consumer of technology has to also be aware of that. And someone's also mentioned NASA as a great resource. So I think they would probably be the two things I would say to have a look at. What a great session. It makes me feel reassured that the worlds are connecting. So that's, for me, I'm going to leave on a positive. But I think my message to people would be connect widely. And I've recently, inspired by Helen Bevan, I've recently started reading stuff by Damon Santola about building wide bridges. And actually, I would recommend that because strong social contacts are actually what's going to make change happen. And I think we've touched on some of it today, but I would recommend that as a read. There's a nice MIT Sloan Management Review paper that's quite small called The Truth About Behavioral Change that has resonated with a lot of what I've heard today. But I think if you don't know your tech colleagues, reach out and have a coffee. Create those relationships. Create them anyhow, not because you need something, because that stands in good stead. And ditto, if there's any digital colleagues on here, reach out to your improvement contacts. And that would be my parting message.
Yeah, thank you so much, Breid. It's all about relationships. I've definitely taken that away from the session as well. Alka, Emma, thank you in particular again to you for sharing your experience and your work, and thank you very much for doing all the work and the impacts had on your colleagues and people who receive care from that. I hope you enjoyed the session. If you've got more questions or reflections, please put them in the chat. We will do a write-up of the session alongside the recording that will be available. And I think we're going to finish with a quick evaluation poll that colleagues are going to put up from that. But with that, a really big thank you from me. Thank you for all of you for participating, and hope to see you in later sessions today. Thank you. Bye-bye.